Hello and good morning, everybody. Um, Today I'm going to discuss the second part of my topic on AKI and CRRT, which will mainly involve the etiology and investigations of acute kidney injury. Coming to the etiology, so classically, etiology of acute kidney injury, or you can say chronic renal disease, even all the renal disease can be divided into pre-renal, renal, and post-renal causes, and that depends on what site is the primary damage happen. So, coming to the pre-renal causes can happen because of hypoperfusion to the kidney, and it can happen because of absolute loss of water. For example, happening in cases of vomiting, diarrhea, diuretic overuse, or bleeding, or burns, or our patient is not able to take adequate fluid. For example, patient have got low GCS. This similar situation will happen in the cardiac disease where hyperperfusion to the kidney will happen because of the low contractility of the heart. Liver disease will actually present as a condition in which there will be redistribution of the fluid, leading to relative intravascular dehydration. Although the fluid content inside the body will be enough, but because of redistribution of the fluid to the extra vascular compartment like peritoneum and pleural cavity, there will be collection of the fluid, leading to intravascular dehydration, and effectively the renal perfusion will be compromised, leading to acute kidney injury. Coming to the intrinsic renal failure, it can happen depending on the site of the damage in the nephron. So it can be happen most commonly because of tubular damage, which is called acute tubular necrosis. Can be caused by different drugs like NSAIDs, over the counter, illicit herbal medication, all those things. Sometimes it can be caused by rhabdomyolysis or hemolysis, where there will be a lot of cell lysis leading to the crystal formation, or a relative blockade of the tubules, leading to tubular necrosis. While if you will go to the glomerular damage, there's a more of glomerulonephritis like situation which can happen to because of the primary glomerulonephritis, or because of the disorders like SLE, systemic sclerosis, arthritis, uveitis related disease like uh, spondylosis kind of disorders. All those disorders will ultimately can lead to the renal damage and present like a glomerulonephritis. And depending on the tri- amount of protein loss, it can be divided into nephrotic disorder or nephritic disorder, along with present of hematuria and all. So we all have read this during our graduation, uh, but here for the intensive care point of view, you might find um, acute, like acute exacerbation of SLE, sometime rheumatoid arthritis patient, and it becomes difficult to um, differentiate between the sepsis and acute exacerbation of rheumatic disorder. And in those cases, you will require to investigate the cause by sending anti-nuclear antibodies or extended anti-nuclear antibodies. So all those things, and then there is specific markers you have to send for the SLE and rheumatoid arthritis. Uh, Sometime it can be caused by different viral infection like hepatitis C virus, human immunodeficiency viruses, and all. Um, a lot of medication can cause interstitial damage like PPIs, antibiotics, while Some of the nephrotic syndrome can be caused by vascular damage, uh, and and sometime because of the vascular surgery. So in those kind of conditions are not very common, but mostly you will find ATN, glomerulonephritis, and sometimes interstitial nephritis in ICU setting. And if you go to the post-renal situation, it's quite more urological situation than actually a medical condition, where you will find obstruction at the level of urinary flow. So it can happen anywhere from the pelvis up to the urethra, and depend if you will say obstructive cause of acute kidney injury is mostly can only be caused when a condition, and there will be obstruction which will lead to blockade of bilateral urinary flow, or somebody who has got solitary kidney, and then there is obstruction leading to hydronephrosis of solitary kidney. While in cases of single kidney, the patient will not present mostly the AKI. They were so when if in case of unilateral blockage, I mean to say, yeah, you will not find AKI like presentation. It will be more of presentation of obstructive uropathy. So if the patient is having bilateral obstruction, it can happen at the level of urethra, prostate, at the level of bladder, but rarely it can be caused by infiltrative malignancy, which is leading to obstruction of bilateral ureter. But it is not very common, and probably before that you will find a lots of uh, secondary presentation of malignancy rather than the AKI as the first presentation. If you'll say for the investigation of AKI, it's quite routine to investigate in ICU. You don't need means we usually send a routine investigation to everybody, and it includes in ICU it includes it's like blood gas, CBC, UNEs. So there is nothing specific if you want to say for the diagnostic of AKI. NGAL is probably an early marker of AKI, but the clinical significance is again not proven, because it may just say that AKI has happened, but does it change the management is difficult to say. So investigation remains a lot routine, and you have to watch on blood gas, specifically related to metabolic changes, metabolic acidosis, or like changes of changes on electrolyte, specifically potassium, magnesium. You have to keep eye on those things, while daily investigation remains similar to any routine patient of ICU. Yeah, this slide is typically important for the examination point of view, and lots of time the examiner will ask you to differentiate between pre-renal AKI and the renal AKI on the basis of lab. You might find it in the European diploma in intensive care examination or FFICM examination. You can find just to differentiate, give some few points to differentiate between AKI. It appears quite complicated, but if you try to make a concept of that, it will become easier for you. So if you say what our body will try to do in case of pre-renal AKI, so the kidney is not getting adequate fluid supplied to the kidney, it will perceive that body is dehydrated, so it will try to prevent the loss of water and loss of sodium. So if you will try to know the urine sodium, it will be lower in the pre-renal AKI. Again, the fractional excretion of sodium which is actually a fraction of urine sodium to plasma sodium in ratio to urine creatinine and plasma creatinine in percentage, is lower in a pre-renal AKI. So the sodium, we can remember, sodium will be less in pre-renal, and FeNA, which is again representative of sodium excretion, will be low in pre-renal. Body will try to preserve water loss, so it will produce concentrated urine. So you will find high urine osmolarity and high urine specific gravity. So, so by the same concept, you can remember 4 point. I'm trying to make it more clear. Body is trying to preserve sodium, so urine sodium will be less, FeNA will be less in pre-renal AKI. Body is trying to preserve water, so urine will be more concentrated, leading to high urine osmolarity and high urine specific gravity. Definitely, if the condition will be pre-renal, response to fluid challenge will be better in pre-renal in comparison to renal AKI. And because most of the pre-renal AKIs are quite means because of there is no nephron damage or tubular damage, so you will find either no casts or sometimes hyaline or fine granular cast on urinalysis, while in the ATN you will find a typical of brown granular epithelial casts. So if you try to remember in the name, I just to summarize, urine sodium will be less in pre-renal AKI, less than 10 millimole per liter, while it will be more than 20 millimole per liter in case of renal AKI. FeNA will be less than 1% in a pre-renal AKI, while it will be more than 1% in renal AKI. Urine osmolarity will be more than 500 milliosmol per kg, while it will be less than 350 millimeter milliosmol per kg in case of ATN. And urine specific gravity, it will be more than 1.020, while it will be less than 1.010 in case of ATN. And there will be good response to fluid challenge in pre-renal, while it will be poor in renal causes of AKI. And there will be brown granular cast or epithelial casts in cases of acute tubular necrosis, while in pre-renal AKI you will either find no cast or sometimes hyaline fine granular cast. Yeah, try to revise it as much as possible. If you are going to face exam, it's difficult to remember. Many times we get confused, lots of numbers are involved, but if you keep revising, I think it will not be difficult. Just keep in the mind what our body will try to do in the case of pre-renal and renal causes of AKI. This slide is approach of patient when they are presenting first time with the deranged renal function or rising serum urea and creatinine. So first, how do we approach? So our approach is as any patient we see in our clinical setting. So we have to go for history and examination of the patient, try to find what is their story. If the patient is oliguric or not oliguric, that is if oliguric, then you have to understand whether the sodium is less in the urine or creatinine is increasing, but the FeNA is low, similar which we have discussed in previous slide. So just to differentiate if it is a prerenal condition, and in the prerenal condition it's quite easy to manage, and just If you are sure the patient is oliguric and creatinine is rising, sodium is low in the urine, and then FeNA is low, specific gravity is high, then definitely it's going towards the pre-renal condition, and then you have to different see whether the patient is uh, hypovolemic or maybe hypervolemic relative intravascular hypovolemia. So here, so if it is volume depletion, you have to give fluid. If the patient is in heart failure, you have to give diuretics. If the patient is again redistributive condition like liver disease has got a different management, you have to probably give albumin to transfer the fluid from an extravascular compartment to intravascular compartment to treat that. But for the initial stage, we can say if the patient is congestive heart failure, give diuretics. If the volume depleted, give fluid. That's all story about the pre-renal AKI. But it become complicated when we go to renal or post-renal. You have to do renal ultrasonography, and if you see bilateral small kidney, then it will probably a CKD situation. Or if it is hydronephrosis, you can say this obstructive uropathy and you have to relieve obstruction. But if the kidney is normal size, this is probably we are talking about the renal causes of AKI, and here it will be a proper investigation. We have to do what may be the reason, and then you have to do the urine analysis of the patient, and then see what are kind of the cast patient is getting, and also like renal tubular cells or renal tubular cell cast are there, then probably it's we are dealing with ATN. If eosinophils or white blood cells cast are there in the urine, then probably we are dealing with allergic interstitial nephritis. Or if the red blood cell or proteinuria is there, then probably we are dealing with the glomerular nephritis or vasculitis like diseases, and maybe multiple myeloma like situation. If you are suspecting glomerular nephritis, probably you have to go for the renal biopsy, and for the diagnostic purpose of multiple myeloma, you have to go for serum and urine immunoelectrophoresis. And so so if you diagnose a specific condition, then you have to treat accordingly. So in ATN, mostly it's a supportive treatment with the withdrawal of the cause. In eosinophilic interstitial nephritis, so you have to mainly eliminate the offending drug and give a steroid. While glomerular nephritis, you have after renal biopsy, you have to decide what type of glomerular nephritis there, and then you have to treat accordingly. And but overall, we have to be we have to continue with our supportive treatment. Appropriate hydration is the thing, and to avoid the nephrotoxic drug, to remember. But you have to see that in cases of pre-renal disease, you have to go for directly management. Otherwise, you have to differentiate with the ultrasound, and it's very important thing to do when you are dealing with unknown cause of AKI. So here we conclude the second part of the presentation. We'll continue on third part with the management of AKI. In the meantime, please subscribe and like my channel. Thank you very much.